results in the inhibition of visible growth of a microorganism is the MIC. As you can see in this picture, at 4 microgram per ml, there was complete inhibition. So, and of course subsequently at the higher concentrations as well. So this is your MIC. Now, common methods for MIC determination we just talked about. Of course, the broad microdilution gradient test. There are automated systems as well. Now, how does an automated system work? We use Vitek2 at our center. For using an automated Vitek2 or any automated system, you need to have culture growth before that. Because it's from that culture growth that the pure isolate is picked up from a fresh colony. Then the inoculum is standardized to define turbidity or instrument verified density. Then it is suspended, and the organism suspension is loaded into cards, panels or wells containing antibiotics. And the instrument incubates and reads the growth signals over time. And software converts patterns into identification and susceptibility results. So this is basically the function of how an automated system works. So just to recapitulate, that you have a blood sample, through virtue you've detected that there is a positive signal. Immediately in the lab, it will be put to a gram stain and a culture. From the culture, a pure colony will be picked up and processed, like we just talked about the Vitek2 processing. The Vitek2 will give you the identification and the antibiotic susceptibility testing, and you will receive your final report, which will guide you to your therapy. Now, this was recently published in JAMA, wherein they compared the rapid antimicrobial susceptibility testing to the standard AST, showing whether it was showing any improved clinical outcomes among individuals with bloodstream infection, which is caused by gram-negative bacilli. So it was seen that rapid blood culture AST for gram-negative bacilli was not superior to standard AST for a more desirable outcome in patients with bloodstream infection. Now let's understand what is MIC. MIC is the lowest concentration of an antimicrobial that inhibits visible growth of the microorganism. So the first tube or well with no visible growth is your MIC. And of course at concentrations higher than that, you would see inhibited growth. So MIC is expressed as milligram per liter or microgram per ml. It is a lab value, not a dose. And a low MIC is not automatically the best drug unless the breakpoint and the site are considered. So everything together has to be incorporated before you actually choose an antimicrobial agent. Let's understand this with an example. For example, your patient's blood culture is doing E. coli and you've tested it for 4 drugs, 4 antibiotics as seen here, A, B, C, D. And you can see that your lab has given you the MIC values. So for A drug it's 4 and for D it's 1. So you are automatically, you think that D being having a low MIC, should you choose drug D because it has the lowest MIC? So the answer to this is actually not necessarily, because different drugs have different breakpoints and achievable concentrations. So MIC becomes useful only when it's compared with the correct clinical breakpoint. And also you must keep in mind that the drug that you're choosing, the organism that you're treating, the dose, the PK/PD and infection site all matter. So it all has to be integrated together in your report before choosing the appropriate antimicrobial agent. Now, what is this breakpoint? So breakpoint is the MIC threshold used to categorize an isolate as S, I or SDD or R, right? Now, if your MIC is lesser than the breakpoint, this means that that particular antibiotic is sensitive. Similarly, if your MIC is higher than the breakpoint, then that means it is resistant. It will not work for the microorganism, a particular antibiotic drug. Similarly, for I and SDD, the breakpoint, the MIC is going to be close to or nearly the same as the breakpoint, which will give you the I or the SDD report. So the breakpoints are actually given by UCAST and CLSI. Every year they are updated and they are based on wild type distributions, PK/PD targets and dosing, drug concentration and infection site, and clinical outcome data whenever it's available. Breakpoints differ by drug, by organism, and breakpoint should be higher than the MIC. So let's again look at our report. I just told you that E. coli was grown on a blood sample, and as you can see, the 4 antibiotics were tested. Look at antibiotic A. The MIC is 4 and the breakpoint is less than 32. So your MIC is lower than the breakpoint. So this antibiotic A becomes sensitive, right? Similarly, look at antibiotic B. The MIC is 4 and the breakpoint is less than 8. Again, your MIC is lower. So again, the interpretation would be that this is sensitive. For antibiotic C, it's near about the same, 2 and less than 2. So again, borderline. So the report would give you I. And for antibiotic D, the MIC is actually higher than the breakpoint because the breakpoint is less than 0.5. So your drug has become resistant. So a lower MIC can still be resistant if the breakpoint is even lower. You must remember this. Now, how do you integrate this into your practice? How would you select? I just showed you 2 antibiotics which were sensitive, which were sensitive, right? So, which one out of A or B would you choose for your patient? This is based on the breakpoint to MIC quotient, which is susceptible breakpoint divided by the patient isolate MIC. Now look at drug A. The BMQ is 8, so more buffer below the breakpoint. And drug B, the BMQ is 2, susceptible but closer to the breakpoint. So higher BMQ suggests more pharmacodynamic space. So you would select drug A. Now, but again, even for BMQ, do not use it alone. Always remember the site you are treating, the toxicity of the antimicrobial that you are selecting, the dose that you're going to give it in, whether you've achieved source control or whether you've done measures to control the source or not, and of course guideline preference. So all this again has to be considered with each of these to be able to select a proper antibiotic for adequate treatment for your patient. Now, there are certain definitions of this SI and STD. So, what are these? S is high likelihood of success with usual exposure. Use if clinically appropriate. I from UCAS means susceptible with increased exposure. Optimized dose, route, and site exposure. Then I from CLSI is intermediate, possible at high exposure of concentrated sites. Clarify dosing and site. SDD is only given by CLSI, which is susceptible dose dependent for defined bug drug pairs. Likelihood of therapeutic success if exposure to the drug is increased by adjusting dosing regimen. And R is high likelihood of failure even with exposure. Avoid unless no alternatives are available. So we keep talking about CLSI and UCAST. What is CLSI and UCAST? These are 2 organizations. CLSI is Clinical and Lab Standards Institute and UCAST is European Committee on AST. They give you breakpoints annually which are updated. And the key table for CLSI right now is M100 and the UCAST version 16 is for 2026. Breakpoints may differ from UCAST for. Now, why does dose and site matter? So there is something known as pharmacokinetics and pharmacodynamics. Pharmacokinetics is the serum concentration, the urinary concentration of the drug, whether it reaches your lung epithelial lining fluid, whether it has some CSF penetration, how much drug is protein bind, how does the renal function affect. And pharmacodynamics is for example, for beta lactams, it's the time above the MIC. Vancomycin, fluoroquinolones is the AUC by MIC. Aminoglycosides, it's peak by the MIC. So dose optimization can change success. Remember, S does not guarantee success if the drug does not reach the infection site or the source control is absent. Then why breakpoints change over time? Because they are not permanent truths and they are updated as evidence changes. Because new PKPD data keeps coming, newer resistance evolves over time, outcome data changes, breakpoints are revised. So lab needs to update. You need to constantly be in touch with your lab and ensure that the lab is being updated annually. Now, when there are no valid breakpoints, what should you do? You should report the MIC without SINR when no breakpoints exist and add a clear interpretive comment. Do not borrow breakpoints from unrelated organisms. You should not be doing that. Now, quality control is another part which is important, especially when your AST reports are concerned. There are various errors at technical level, at system level, and even at the lab level. So, like, let's look at one of the errors at the lab level, which is like a major error, a false susceptible report, which is very dangerous. You've received a report which shows that your organism is susceptible to a particular antibiotic, but the truth is actually resistant. So, what would it do? It would actually result in a treatment failure. So, it is very important that quality control is maintained and it's regularly uh, maintained by your labs. And if you do get an unexpected result, you should repeat the sample. You should send a repeat sample. You should discuss with your lab. You should confirm the result again before just jumping on and treating the report. Now, MIC is important for every drug, an antimicrobial that you test, but it is essential in certain cases, like colistin for enterobacterials and Acinetobacter, because disk diffusion is unreliable and there's a narrow therapeutic index. Vancomycin or daptomycin for S. aureus, because small MIC differences can affect serious infection. Penicillin or ampicillin for strep viridans, because in sterile sites, because it can defer your decisions when there is endocarditis, bone, blood, or CSF infections. Xenotrophomonas maltophilia with selected agents, you must use validated methods. So another pitfall, when you talk about antibiotics and organisms, there are certain pitfalls. Another one is the intrinsic resistance. Now, your report may show that the bug is sensitive to that particular antibiotic, but because of intrinsic resistance of the organism, the antibiotic may not be effective for your patient. For example, aminopenicillins for most gram-negative bacilli, even Bacteroides fragilis, cephalosporins, like in cases of Enterococci, Listeria, atypical, Proteus vulgaris and Providentia for first generation, carbapenems for MRSA, Enterococci, Stenotrophomonas, and Burkholderia, aminoglycosides for anaerobes, tetracycline for Proteus species, polymyxins for all gram-positive organisms, and even for Proteus, Serratia, Morganella, and Burkholderia. So even if these organisms are sensitive, these antibiotics are not going to be effective because of the intrinsic resistance. Another pitfall is one is intrinsic resistance, the other is the site-specific antibiotic. It will show that the antibiotic is sensitive, but the antibiotic does not penetrate that site. So again, it will be ineffective. Like in urine, macrolides, moxifloxacin, chloramphenicol, clindamycin, poly, they don't penetrate. In lung infections, gram-positive daptomycin is inactivated by the pulmonary cell factor, so it will be ineffective. Colistin does not penetrate the pleural space. For bacteremia, TG-cycline is not a good drug. In CSF, macrolides, clindamycin, tetracyclines, and aminoglycosides, as well as first and second generation cephalosporins, have a poor penetration. So you must remember the site as well before choosing the antibiotic for your patient. Now let's look at these cases. These were shown by Dr. Kamila Rodriguez, and we're just going to look at them again. So this was an 18-year-old woman with dysuria and frequency. Urine routine was showing pyuria and nitrite positive. Empirically, the patient was put on amoxicillin, and when the culture report came, it showed E. coli and ampicillin was resistant with an MIC of 32. But the patient, when comes back after 5 days of therapy, is doing very well. So you are provoked to think that, is your report wrong? Should you change the antibiotic because it's showing a resistance? What infection site is being treated, and what concentration does the drug reach in the bladder? This was a case of uncomplicated cystitis. Now, many AST interpretations are based on serum achievable levels. In cystitis, some drugs reach much higher urinary concentrations. So as you can see that the bladder concentration was 600 micrograms. So ampicillin at 32 is still effective in cystitis. However, if this was a case of pyelonephritis, sepsis or meningitis, then it needs more systemic exposure. So if your patient is not getting better, at this point, you need to reconsider an antibiotics and change if it is needed. So do not extrapolate urinary success to bacteremia and use serum and organ-specific breakpoints in severity assessment. For cystitis, bladder concentrations may exceed the serum-based breakpoints. Some drugs have urinary breakpoints. So clinical alkalizing agents for dysuria. So you must remember when you use an antibiotic nitrofurantoin that the effectiveness will go down. However, there are some antibiotics which are effective in alkaline urine, like the sulfonamides, kanamycin, colistin, tetracycline. So these aspects also need to be considered before actually choosing the appropriate antibiotic. Now again, a specimen of urine sample from a patient which was growing Proteus vulgaris, and you can see the sensitivity report. So what antibiotic would you choose for your patient? Now remember that you have, the report is showing Proteus vulgaris. Now Proteus vulgaris, Providentia and Serratia are resistant to ampicillin as well as first generation cephalosporin. Proteus species are also inherently resistant to nitrofurantoin and tetracyclines. Nalidixic acid sensitivity predicts susceptibility to all fluoroquinolones, but your report is showing resistance to your fluoroquinolones. And chloramphenicol does not achieve adequate levels in urinary tract infection. So, from this report, with all this, I don't think I can select any drug. So, each of the organisms, when they're isolated, you need to remember that you cannot blindly jump onto the AST report and start treating. There is intrinsic resistance, there is site, there are other things that matter which always should be remembered. Another case of a 65-year-old smoker and diabetic with right upper lobe pneumonia, ceftriaxone for 4 to 5 days. Sputum sample was sent after the antibiotics, and the culture of this patient from sputum grew Enterobacter agglomerans and Candida albicans. Now remember that for a sputum sample, it's a non-sterile sample first of all. I told you that the antibiotics were already started and the sputum was sent. So antibiotics select colonizing flora. And Candida in sputum rarely means Candida pneumonia. So don't escalate to carbapenem just because the colonizers look resistant. This is another very important aspect before just jumping onto changing antibiotics because the culture sensitivity report is showing something else. So remember, if you're unnecessarily treating resistant colonization flora with broad spectrum drugs, you are generating more antimicrobial resistance. And if you're treating a colonizer, you may actually miss a true pathogen or a non-infectious cause for the patient's problem. Now, another aspect in pneumonia is, non-responders. So it's not just your AST report that matters. You need to reconsider, relook. Are you treating a wrong pathogen? Is it a viral infection or tubercular? Has a complication occurred like an abscess or a parapneumonic effusion? Is the diagnosis wrong to begin with? Is your host immunocompromised? Has comorbidities like diabetes? And treatment factor. Have you chosen the right dose? Have you selected the antibiotic which penetrates the lung? And have you ensured source control? Because if you should not just treat the report, treat the patient plus the syndrome and always look at the microbiology simultaneously. Now for blood culture, how do you differentiate between contaminant and true bacteremia? Bonds in one of one set is often a contaminant, so you should repeat cultures, reassess your lines and processes. Cons in one of multiple sets is again usually a contaminant, so do not jump onto adding a gram-positive cover. Cons in multiple sets is more likely true bacteremia. You need to evaluate your catheter, prosthetics, as well as look for endocarditis. Staph aureus in blood is usually clinically significant. It's a serious infection and you must look for source. Then, source control dictates response. So you need to identify the focus, remove the drain or the line if that's the culprit, culture properly, ensure that the antibiotic that you're selecting reaches the site of infection to achieve a desired clinical response. Like in case of empyema, drain the pleural space, relieve the urinary obstruction, remove the catheter if that is the source of infection. Persistent fever with an S report should trigger source control review, always. Now, another case of a patient with repeated blood culture positive Staph aureus infection. Patient was on vancomycin for about 10-12 days and suddenly starts worsening, now develops multifocal septic arthritis, spondylodiscitis, vegetation. And the report is showing that it is still, the Staph aureus is still vancomycin susceptible. So then, you are provoked to think that is the bacterial burden high, is the focus more deeper, is MIC near the upper susceptible range, or the MIC is it the MIC creep? Now, what is MIC creep? It's a gradual upward shift in MIC values over time. While the lab may still report the isolate as susceptible. Let's look at this with an example for vancomycin, MIC, and MRSAs. You can see Initially it was 0.5, but then gradually it kept creeping and reached near about the breakpoint 2. So it is, still susceptible, but the MIC has creeped. So when the MRSA vancomycin MIC is near about 2, then you need to reconsider if the patient is not improving. If the patient has pneumonia, you can consider linezolid when it's clinically appropriate. In cases of bacteremia, you can consider daptomycin. Then vancomycin and the MIC basically. So if the MIC is less than the breakpoint and the patient is improving, then you continue if the exposure is optimized and the source is controlled. If the MIC is less than the breakpoint but there is persistent bacteremia or worsening, reassess source control, repeat cultures, consider alternative therapy. If MIC is more than the breakpoint, then there is a concern of VISA and VRSA. So avoid using vancomycin. And for serious MRSA infection, aim for AUC by MIC targets with therapeutic drug monitoring. Avoid underdosing in such infections. So, rapid AST is something which is very helpful and is very widely used these days. But when it is used, it should be paired with a good sample, quality control, stewardship, clinical and microbiologist communication. Because rapid EST would help you in early targeted therapy, earlier de-escalation, reduce unnecessary use of broad spectrum antibiotics, and better ICU decision making. But the speed alone will fail when wrong specimen or colonizer is misleading you. So you need to remember that it has to be integrated together. Now, when you get an AST report, how does an ideal AST report look? It should state the organism and the specimen clearly, provide MIC where clinically important, show the breakpoints or the interpretation basis, use current and updated CLSN and UCAST versions, suppress drugs with intrinsic resistance, add comments for no breakpoint situations, and flag urgent results for bloodstream and ICU infections. The best report is not the longest. It is the report that prevents wrong treatment. Now, the lab has to maintain quality control and a checklist, but a clinician should also remember a checklist before jumping onto the AST. Are you treating a true pathogen or a colonizer? Was the specimen taken before or after the initiation of antibiotics? Is the patient improving or deteriorating with the treatment that you started? Does the drug reach the infection site? Is MIC close to the breakpoint of the antimicrobial that you've selected? Has the source control been achieved or not? And does the guideline here match the current standards? So this is a checklist that you must always keep in mind before actually acting on your AST report. So the stepwise bedside algorithm is that you confirm infection, confirm the pathogen, check the site, read the report with MIC and the breakpoint, optimize the dose, and control the source. If there is severe illness, prioritize reliable early coverage and then de-escalate. Do not force SINR. You should seek expert inputs. So just to summarize the definitions, MIC is how much drug is needed in the lab to stop visible growth. Breakpoint is the cutoff that converts MIC, the zone, into your report of I or SDD or R. S is likely to work if the right dose reaches the right site. R is likely to fail, avoid if alternatives exist. CLSA and UCAST are rule books, but remember that the once you've identified the organism, the right drug, the MIC, the site that you're treating, the dose, whether you've achieved source control or not, and assess patient severity is how it should be clinically interpreted and put into use for treating your patient's infection. So, AST is a decision support tool. It is not a substitute for clinical judgment. Thank you.
Thank you, Dr. Aakanksha, for recapping the last two talks, and you've done the justice to the topic. And now I will introduce the moderator for today, Dr. Jagiasi, who is a very well-known intensivist in India, very famous in Mumbai, and he is currently the Director, Critical Care, Kokila and Dhirubhai Ambani Hospital, Navi Mumbai. He's achieved a lot of awards and has done great work as an academician. He He was General Secretary of ISCCM, Indian Society of Critical Care Medicine, 2024 to 25, Organizing Secretary for the Critical Care 2025. He's been Examination Secretary for ISCCM, extremely active in the Indian Society of Critical Care Medicine. He's also been the Treasurer, and he's been Zonal Member of also the West Zone. He's been Examiner, Teacher, Inspector of ISCCM courses. He's faculty in more than 100 national conferences. He's been chairperson of a lot of guidelines which have been brought by ISCCM, HFNSC, ARD, ARDS, DVT, NIV guidelines. And he's also the editor of the ISCCM textbook, one of the editors of the ISCCM textbook of critical care medicine. He's got a lot of publications. He's been reviewer for the Indian Journal of Critical Care Medicine, Anesthesiology, Clinical Pharmacology. He's been awarded Fellowship of Indian Society, Indian College of Critical Care Medicine, and has been receiving President's Citation Award for 7 consecutive years. And he's been recognized as a top doctor in Mumbai. So I hand over to Dr. Bharat Jagiasi, who is going to conduct the today's proceeding.
Thank you very much for the kind introduction, and it's nice to have you. And Aakanksha, amazing talk. It was very well overviewed and summarized. How do we interpret, especially when you covered the intrinsic part of the resistance, and also we have to consider whether the antibiotic is being escalated in a certain area or not. So, as we have the next talk, Dhruv sir, please allow me to share a slide to also introduce you. If you could stop share. Yes, sir. It's my pleasure to introduce Dhruv sir, because sir has been my mentor, and I was also a joint secretary of sir when he was president of ICCM, and he's been guiding me all throughout. He's head of Pulmonary Critical Care Medicine Department at PGIMS Rohtak, and to Chawla, he's Dean Academics at Rohtak, Professor in HR Research at Rohtak, and also he's president of Association of Common Health Scholars and Fellows India. He's been a past president of Indian Society of Critical Care Medicine, where I had the opportunity to work along with him as his joint secretary. It was COVID era. We did lots of things, and he was a leader to guide us and always to support us. He's been a chairperson of Ethics Committee, Central University, Haryana. The chair member, multiple task forces in pulmonary critical medicine. He also serves many roles in the health ministry, and we always seek his guidance whenever we have an issue. His achievement science fellow of the National Academy of Medical Sciences, Commonwealth Fellow in Pulmonology, Liverpool. He's a recipient of Hansraj Nair Award and honored by Haryana Medical Council, Government of Haryana, IMA for COVID work, and has got multiple oration for professional bodies, and we've been part of those many, and it's been a great learning from him. Publications, more than 154 research publications, 55 book chapters, has been section editors of 4 books, and he's also was the one who was one of the first editor of the ICCM textbook of critical care, that is the first edition, and also co-editor of Postgraduate and Medicine. And today he's going to talk on the management and treatment of the diagnosis of the empirical community-acquired pneumonia. Sir, over to you, and all virtual stages you are there. Thank you.
Thank you, Bharat. Let me share my thing. I think, just give me. Yes. Is it, are the slides visible? Is the slide visible?
Yes, sir.
Thank you, Aakanksha. Yeah. Good evening, everybody. Right at the beginning, I am grateful and thankful to Dr. Rajesh Chawla, the whole NCCP leadership, including Dr. God, also along with him, Professor Katyar, and so on and so forth. Thank you, Dr. Chawla, for conceiving this brilliant course in respiratory medicine. As usual, nothing short of this is expected from you. When he asked me, I will be happy to talk about it, as it's always a pleasure. And next 25 to 30 minutes, I shall be discussing about pneumonia, especially community-acquired, diagnosis and empirical treatment. But before I started, I think what Aakanksha told today probably let us know that how the basic sciences and the clinical things, they meet each other. I think that is fundamental of clinical sciences, and that's what we are also going to see here, how we see clinically and how we look into take decisions which are important and how the basic sciences are shaping our understanding. And now let's start our journey for next 20-25 minutes. We all talk in terms of different type of pneumonias. Pneumonias, basically, we take it as an infection of the lower respiratory tract, in particular alveoli, but there have been different names which have been given. And we are talking here in terms of community-acquired pneumonia. Now, IDSA ATS definition of 2009 becomes the benchmark today, which has evolved acutely. In other words, they have taken a more practical view that anybody who has got a lower respiratory tract infection, which will tracheobronchial area and then going down, along with it, when you find out that you start getting a wheezing, you start getting a localized crepitations, or you start getting a signs of consolidation in terms of bronchial breath sounds, and with which, if you have one more systemic feature, besides cough and expectoration, if you have got a fever along with it, then probably we say and confirm it with the radiography, yes, this person has got pneumonia. I think it is very, very important. And European Respiratory Society and European Society of Critical Care made it a little more simpler. And they said that it is an acute LRTI with new infiltrate. So if somebody comes to with an acute symptoms of cough or along with it has an expectoration, if you see an X-ray chest, new infiltrate is coming up, it's a pneumonia for all practical purposes. Whereas the hospital-acquired pneumonia, the study definition is that new pneumonia more than 40 hours, 8 of admission, and it includes VAP. Now, what is very important for us today, this distinction has been kept because sometimes people come and they are evolving from the infection, and to give that pace a time, that's why the duration has been kept 48 hours. Healthcare-associated pneumonia has been abundant, but VAP was part of it. It has been taken up because in the Western world, the etiology was different. In these, the gram-negatives are much more than the other common suspected pathogen. But then they realized over a period of time that this distinction of putting it separately should go away. But nevertheless, we must remember when we talk in terms of VAP, I'm not going to discuss because this is a different chapter about it, that distinction of early and late VAP is also going up because the evolution of medicine and evolution of your microorganisms, the way it is happening. Before we start anything, epidemiology is extremely important. First, let's look at the global context because we have a reasonably robust data which is available to us. And the global burden of community-acquired pneumonia is that it is the 8th leading cause, especially in US. Same is true also in UK. Then, nearly the low respiratory tract death, but it's the worldwide cause throughout the world when we put our children along with it. And when you start looking at it, the gap that the community-acquired pneumonia, nearly 1/4 of the people who have got a community-acquired pneumonia and got hospitalized because of this will need intensive care units. And the question doesn't end there. The conundrum, the travel which one starts, the march which comes starts here, continues. And what one is finding is that even up to 1 year, the mortality, the people who survive from the severe pneumonias, especially those who have been hospitalized in the ICU, recover. 30% of them we may lose by the end of 1 year. And so obviously routine hospitalization, and it steps up to 50% if people have got admitted in intensive care unit. And very important is that pneumonia is a very common risk factor for increased incidence of myocardial infarction, stroke, heart failure, and this persists even post-discharge because it produces intense inflammation leading on to endothelial dysfunction. And when you start looking at the Indian context, now when we look at it, roughly 4 million cases are supposed to be there. It is a guesstimate per year in India. And out of them, 1 in 4, 1 in 5 of them is going to be admitted. That is 20% are hospitalized. Then 5 to 11 per 1,000 adult year annual incidence is rough guesstimate, because of which we are saying the absolute numbers. But when you go to the children, and this data is for the children, then 1/4 of the children, the child less than 5 years of children, 1/4 of them is in this country. And obviously the outpatient mortality is not very much, but still it is less. On the other hand, when you start looking at the children under 5 years, every hour 40 children are dying because of low respiratory tract infections as well as pneumonia. And when we look at the total aggregate of it, Southeast Asia regional CAP, WHO, so the CAP burden in India, of especially children of the whole CRO region, is that more than 1/3 is in this subcontinent. Before we move further, we need to know the pathogenesis. What is very interesting today is that we can use this word, which is becoming more, as you will go in future, you will use more and more of it. That is microbiome dysbiosis to alveolar consolidation. I think that's very, very fundamental. And we need to, usual conventional teaching is that there are 3 routes of microbial entry. Microaspiration, which is supposed to be the commonest cause, 50% of healthy aspiration. People aspirate during sleep. Then is the direct inhalation small droplet nuclei, which are smaller one. This is what we see in viruses. That's what we saw in COVID. We see in influenza. And along with it, you have a Mycoplasma, Chlamydia, and Legionella. There is another group of things which we commonly see is uncommon, though what is seen, and that is the right-sided infective endocarditis, when you have a septic embolization, which can happen. And also within the hematogenous spread is another one which we need to be there in the endemic areas of South India. But recently also we saw a patient of Burkholderia, that is the malidosis. But what is very interesting, what is we are learning over a period of time, and you can say is the lung microbiome. Conventional conventional teaching is that lower airway is sterile. But what we are finding today is that lower airway is not sterile. It carries a low density microbiome. And what happens is if somebody has a pneumonia, they have to break through this microbiome. That is, it is the abrupt breakdown of microbiome homeostasis and just not invaded by a new pathogen. Because quite often you will see when you do the upper respiratory tract, a lot of these people harbinger H influenza, they can have a pneumonia and quite a few viruses also lying there. And it is when this particular lung microbiome, which is defensive, which is protective, when that gets broken up today, we see. So this is an essential paradigm shift we are seeing in the pathogenesis of it. Now, what are the host defenses which we see? Most important is the mucociliary escalator, and those people who have a smoking, who have a viral infection. And another factor, if you see the number of studies of corticoids in asthma, and also now we are seeing in COPD, there were higher incidence of pneumonia or bacterial infection precisely for this very reason. Similarly, the patients who have got a surfactant protein and D, they have deficiencies of it, then we can have increased incidence of pneumonia. Alveolar macrophages are very important because they tend to clear, they are the sponges, and once they clear it up, they undergo apoptosis. So if we find any challenges there in terms of apoptosis, or they are not able to clear it up, that's how the pneumonia starts. And this is one of the theories also from the mycobacterial tuberculosis, leading on to TB in these cases. Further, we see that within the cellular parameters there in the lungs, the parenchyma, neutrophils are recruited along with Th17 cells, and obviously they get activated when we find it out that macrophages are overwhelmed. And it is then the collateral injury takes place from pneumonia, you tend to see ARDS. On the other hand, 2 things which go commonly together, influenza and pneumococcus, which we find it that the neuroaminidase, which is there with the influenza, it exposes salicylic acid, leading on to increased adherence of streptoneumoniae, leading on to post-influenza bacterial pneumonia. Another organism which also creates this sort of a challenge is Staphylococcus aureus with influenza. Therefore, when you see today, what we are finding is a number of patients who are having a bacterial pneumonia are having associated on molecular diagnostics viral infection, and a fairly large number of one, because it interferes with the defense mechanisms of the respiratory airways. When you look at the microbiology, the conventional teaching is that community-acquired pneumonias are primarily because of bacteria. But when you start looking at it, the data very clearly shows is that whatever the rigorous testing we have done it, we have not been able to identify pathogens in more than 62% of the cases. And in these cases, obviously, when you start looking at the viruses only, or the bacteria only, or bacterial per viruses, then you will see viruses only are seen in 23% of these cases. Combination of bacteria viruses, which is 4%, and bacteria only 11%. And what we are finding is the rhinovirus single most common pathogen, whereas Streptococcus pneumoniae, when you still the total duration of this, a data which was published in the New Journal of Medicine was 5%. And if you have seen it recently, the pandemic of COVID, also before that influenza, and we also now having a robust data coming from 1980 when people started talking in terms that there was definitely influenza, and influenza was far more commonly associated with bacterial pneumonia than COVID. And today with the PCR-based multiplex assays, we are able to detect number of pathogens in less than 6 hours. But what is very important to differentiate is, which we are seeing antibodies are being studied effectiveness with them, is primarily to know that whether they are the carriage of the colonials or they are the infection and really causing the pneumonia. And now we have started looking at the quantitative patterns in diagnostics, especially with new age PCR assays. When I look at the microbiology etiology in Indian CAP, pooled data over a 1643 study, out of the bacteria, obviously the strep pneumoniae continues to be responsible as the major pathogen. Nearly 1/3 of every 3 bacterial pneumonia, 1 will be strep pneumoniae. Klebsiella is also picked up and is nearly 1/4, followed by streptococcus, by the staphylococcus, Mycoplasma pneumoniae, Legionella, and also Chlamydia, which are atypical organisms. You can see that they constitute nearly 18% if I to combine them together. Another very interesting organism which I have been teaching in the pediatric age group, but we are seeing in adults now very commonly is Haemophilus influenzae, and obviously this has been made far more possible because of the molecular diagnostic methodologies besides the bacterial culture. When you start looking at the hospitalized adult CAPs in the North Indian population in 225 cases, nearly 30% of these were strep pneumoniae, followed by Legionella. The usual belief is that Legionella we don't see, but today when you start screening it up, in nearly 18% of these cases, followed by influenza viruses. Mycoplasma pneumoniae constitutes 7.2, and Mycobacterium tuberculosis never ever forget, because that also constitutes to be very, very important. So in nutshell, if I summarize this thing, strep pneumonia is number 1 bacterial pneumonia, along with followed by Klebsiella pneumoniae if you have got additional morbidities. But Legionella, influenza, and Mycoplasma are not uncommon. Therefore, when we are making a diagnosis, you need to look into it, because the empirical antibiotics will entirely depend upon the organisms which are likely to be the cause of this. And in our college, I was looking at our pool data also, because we are doing now molecular diagnostic testing for last 3 years. Out of the 300 plus cases which we have done it practically in the pneumonias, nearly 40% plus had pooled viruses and pneumonia, and we never used to see the culture, but we are seeing strep pneumonia as number 1, followed by H. influenzae and Klebsiella in our setting. So you need to know your hospital, you need to know your institution, what sort of cases you are seeing it there. And this is something which is troublesome, rising Klebsiella in Indian camp. And we are finding number of them are coming up to MDR. Earlier it's supposed to be used to be commonly with an alcoholic, what is the Friedlander's pneumonia. But looking at the alcohol, if I look at the risk factor, we look by a large number of these patients, classical picture has been described right upper low, with the bulging Fisher sign of Friedlander's pneumonia, with the, when spitting it out, frothy red sputum, which is there. So, but all said and done, pneumococcus is there. Another important part which I will say is that never ever forget the TB. It's a great masquerader. And we need to see that anybody who has come to you with an acute condition, please do look at it. And atypicals are tested because we do not have the facilities. We did not have the facilities. But today, we have started looking at it. At least we are able to make a diagnostic with the availability of multiplex PCR, the molecular diagnostic test. But if you start looking at urinary antigen, because they're quite expensive, hence people don't usually do it, because you can treat the patient in which one test costs you. Same is also true for PCR, for your pneumococcus. But one point we need to remember very, very clearly, my dear friends, is that urinary antigen ideally should be there. But when you start looking at empirical outcomes, probably whether should or should not we go, that becomes a big question mark. But what is important for the Klebsiella, you remember, as I said earlier, is MDR. But interesting study, this is a picture which came from the CMC Vellore. They found Klebsiella as the number 1, followed by Pseudomonas, and then Streptomyces. That's why I said it, please know the place where you are. and along with Staphylococcus, but these are the culture-based results. And culture, we always know that streptococcal pneumonia, we have a difficulty in growing up. Pseudomonas, Klebsiella, and Staphylococcus are far more resistant organisms, in fastidious organisms, where we can pick it up. And interesting part is nearly 44% of them are MDR. So it is important for us, whenever we see gram-negative, please look at ESBL and other drug sensitivity pattern. So therefore, whatever the IDS or ATS say, they may not technically be applicable to our country. And most important, that we need to have antibiogram of each of our institutions. Now, drug-resistant pathogens, when you start looking at it, prior MRSA infections, if somebody has a recurrent skin or soft tissue infections, have got a severe community-acquired pneumonia, and along with it, if you find that people have got a nematoceles, or person has got a viral, especially influenza, in the post-influenza basis, you need to look at it. So commonly in X-ray, you will see cavitation, hemoptysis could be there, or abscess or pus formation there. This is important to realize as for the staphylococcal, and under them also MRSA, where people have been using these antibiotics. Pseudomonas, you need to have a structural lung disease, especially bronchiectasis, and a person is requiring ventilation. On the other hand, in enterobacteriales, you need to see male sex-aware disease, and obviously diabetes and parenteral antibiotics or contact with the hospital has been there earlier. Now let's look at quickly at the case originated in the first stage. A 28-year-old previously healthy IIT professional, 4 days of fever, productive cough with yellow sputum and right-sided pleuritic chain. When you see radiology, person was febrile, but he has a nearly 96 per minute of heart rate, respiratory rate was not markedly raised, BP was normal, saturation was there, but on clinical examination, we had cracked the light lower zone, and when we looked at it, there was a patch here, a consolidation. Consolidation you see with an ear bronchogram, and this is what we are seeing on the right lower zone. When we did the initial workup, he has a total leukocytic count of nearly 12,800, and along with it, he has a normal urea and creatinine. CRP was markedly elevated because sometimes people take it as a distinction. It is less than 20. They try to rule out pneumonia, but that is empirical thing. But by and large, when inflammation is there, this will be high. And the question which arises: where do you treat this patient? Outpatient, inpatient? What investigations are not needed? What is your empirical antibiotic regime? Now, when you start looking at the severity assessment, there are multiple scores which are there, but we commonly use the British Thoracic Society, which gave us, it's a FAST, it's a bedside. We see curve 69, and in this case, if you see that the criteria looks at whether there is a confusion, whether the urea is elevated or not, whether the respiratory is very high, blood pressure systolic less than 90, or even diastolic less than 60, and age is more than 65. If you look at the severe sepsis guidelines, quick SOFA is nothing else, but actually the first three things. URB, that is what we look at it. CRB, you can take up the urea. If you take CRB, it is nothing else but is quick SOFA. So if your score on this is 0 to 1, it is outpatient. If it is 2, short admission, you can, more than 3 people have to be hospitalized to ICU consideration. IDS, ATS is, they look at a better discrimination at low end, and a higher end doesn't make that much of a difference. There are 20 variables, each giving 5 risk classes 1 to 5. So it is far more cumbersome. But what is very important to hospitalize, and you need to give an ICU care. So the outpatient, the question is how to diagnose it. What is the recommendation of 2019? Some things have been upgraded 2025, but there has been a dichotomy and there has been a divergence between IDS and ATS. Therefore, I'm sticking more to 2009 where there is a consensus. And here you will see there is a clinical assessment and chest radiography. Pulse oximetry today is with each chest physician or with a general physician. What is very important to look for the influenza if it is circulating in the community. And it's very surprising in the North India. Even now the summers have come up, we'll continue to see influenza this season. In the last 1 month, I have seen nearly 25 plus cases of influenza. Maybe changing weather, changing pattern, we need to look at it. And severity scoring, ideally should be do with the curve 65 and the clinical judgment. Very important is to have the clinical judgment. And what you find here is not recommended for routine outpatient CAP is you do not go for aggressive investigations, whether it's a cultures, whether it's a urinary antigen or procalcitonin, which our younger colleagues are extremely fond of, and there's no need for routine follow-up imaging. I think this is an important lesson, and this is what the BTS talks about in terms of management. This was published in Lancet. You can take the photograph of this. It can help you out that in outpatient, if you see it here also, nothing is needed and required. Simply have a radiology, clinical profile, which give antibiotic. As the severity, excuse me, as the severity increases, then obviously patient you have taken for observation or you have not taken it into high dependency unit ICU, your investigation things they keep on escalating. The ladder for investigation keeps on going up. There you need to do a sputum culture, you can do a blood culture, you have to do a regional antigen or pneumococcal antigen. Invasive tract samples are not done unless or until person is on ventilator. I think that is very important. But which is redefining here is a nucleic acid amplification or next generation sequencing, which is the film array, which I have been informed by Dr. Chawla has already been discussed. But that does give you a low respiratory tract sample, have to be come from inside, not a saliva, which we need to use to make the diagnosis. Empirical therapy, as far as the outpatient cap is concerned, if there is no comorbidity, monotherapy is good enough. All data talks about amoxicillin, but in Indian context, by and large, because we are using beta-lactam inhibitors, because our NCCP ICS guidelines have said that, and also the same has been told by the IJMR, have been told to us by the ICMR guidelines from the management. But doxycycline is something which is being underused. Macrolide, we must use it, but remember one thing, we still need to know what is the local pneumococcal resistant data. It is increasing, but if it is more than 25%, then macrolide is not. So again, you need to know the area. So quite often, we use in these patients combination of amoxicillin with the clavinic acid and or alternative doxycycline. Personally, we are using a lot of doxycycline in our outpatient setting, and results are excellent. When you talk in terms of an outpatient with comorbidities, here you will again talking in terms of even the Western data is talking in using a beta-lactam inhibitors. That is what we need to use it up, or depending upon whether we want to add macrolide or doxycycline. In most of these cases, quite often when we use a combination with amoxiclavinic acid, and we think there is an additional, probably because of comorbidity, there may be a probability of having atypical organisms, or to cover up for any resistance, we use this combination. Monotherapy can be used. It's not that we don't use it. We do use it, especially when we are seeing influenza infection and has a poor response to amoxiclavinic acid. But otherwise, we must resist from using fluoroquinolones in the country because of its very important role in the management of IMH resistance, monoresistance, or also in the drug resistance. So that is a very, very important part. And less than 15 years of age, we need to be careful. Usual recommendation less than 12 years, but it can create problems in the children, especially in the cartilage growing children. Second case is a 68-year-old smoker, has a serious COPD, is on treatment for triple therapy, has a 3 days issue of component sputum breathlessness, and along with it altered sensorium for 6 hours, brought to ED by the family. Patient is febrile, has a marked tachycardia, has a hypotension, even after giving crystalloid, has marked tachycardia, is hypoxemic, and also has a little drowsiness because if you see the G15, when you auscultate, patient has a bilateral crackle and lactates are more than 4. And what you find when you do a blood gas analysis, you realize there is a type 2 respiratory acidosis along with type 2 respiratory failure along with hypoxemia, and this patient was put on NIV, and there was also a significant PA2 ratio, and X-ray showing us bilateral nodular multilobar consolidation. So this is a severe cap. Every minute matters. That's what's important. The question is where this patient needs to be treated. That's where the ATS-IDSA major criteria. How many minor criteria of the ATS-IDSA does he satisfy? And we need to admit him where? ICU flow. And how should or should not we cover it for MRSA or Pseudomonas? Empirically, and this is important because I'm seeing prescriptions across the board. People start either carbapenem and along with the glycopeptide, that is either ticophenid or vancomycin without putting emphasis on this. So I think this is very important, and it's a very simple criteria. Septic shock requiring vasopressors, need for invasive ventilation. This patient is a vasopressor. Obviously, this patient that means needs to go to the ICU. Also, what is very important is he has a tachypnea, he has a pH temperature as a 250, has a multilobar infiltrate. Patient also has small mode of confusion. There is, we still but any of these three are there. If even one major is not there, then these minor, the patient has to go into the intensive care unit. Also consider hyponatremia, unexplained metabolic acidosis and increased lactate. If somebody who's a non-diabetic starts getting hypoglycemia or alcohol withdrawal, somebody, because number of patients we are seeing are alcoholic addicted, if they come to you, it's better to take them in intensive care, which is very important. So need for non-invasive or invasive ventilation is important. As I said, and I repeat again, our patient had a one major but multiple minor criteria, so it was a swear cap and patient was shunted. So when you want to investigate a patient in swear cap, you need to do culture, both sputum as the blood, preferably 2 cultures before you start antibiotics. And if intubated tracheal aspirates, be sent for culture. Multiplex PCR, I've already talked about it. It gives you a lower panel, can give you both viruses, atypical, typical organism, and you know what you are doing. And similarly, it can tell you Staphylococcus aureus is there, and if it is there, it is methicillin sensitive or MRSA. That is what we are getting. Imaging is constant. Usually we do CXR, and another thing which we had started doing is a focus at the bedside, that's the ultrasonography, which gives us a beautiful picture of like liver looks like some blood consolidation, looks like river. That is why the pathological terms are appetization along with air bronchogram. You differentiate it from collapse by looking at there is a dynamic air bronchogram where the air comes like a white line going and going out. Plus, it can tell you the complications which have happened in this patient. It is in this group of patients, ideally you should think in terms of doing a urinary antigen test. MRSA nasal swab may probably be done if person has a history of repeated infections of the skin, oil, etc. And if it is negative nasal swab, practically you can rule out MRSA. On the other end, positive predictive value is only 50%. So negative has a far important value than the positive. Biomarkers, routinely we don't look for the diagnosis, but looking at a follow-up and de-escalation can be helpful. So the severe cap, when you start looking at empirical therapy, is a beta-lactam plus beta-lactam inhibitors and macrolide preferred. Cover MRSA only and only if you find that person has the risk factor and Pseudomonas if there is a structural disease and there is the recurrent infections. Macrolides, usually we take it up beta-lactam, ceftriaxone or ceftriaxone with beta-lactam, that is the sulbactam, you can take it up. Similarly, like you have an ampicillin sulbactam or amoxicillin sulbactam plus macrolide, we are commonly using as a thromycin, and also earlier people used to use clarithromycin as well. Alternative is that you can use respiratory fluoroquinolone, but use it only if TB has been excluded. Not. I've already talked to you MRSA cover only if you have the risk factor prior MRSA or parenteral antibiotic given in last 90 days. And here you can either use vancomycin or ticoplanin, but alternate could be linezolid. Be careful in diabetics because it contains, it is a solution, is it 5% dextrose. And clindamycin you need to add if you find there is a necrotizing or cavitria. So what is required is that even if it is a Staphylococcus aureus, you are using MRSA, but then if you find a lot of cavitation is there, then that does help. On the other hand, if it is a Pseudomonas cover, it's a swear cap risk factor you need to see bronchiectasis and a prior Pseudomonas thing. And the drug every uridopenicillins, that is piperacillin-tazobactam, give drug sensitivity. You can use other fourth generation cephalosporins, and ceftazidime is the proper one, but because of the drug resistance today, we need to look at and use ceftazidime, avibactam. Carbapenems can be used, but with the NDM which is coming up, it may not have a drug of choice. And there now you will be using ceftazidime, avibactam with azithromycin in these cases. I think that is very important. That's where the molecular diagnostic tests are of help. Pipertazo does work in NDM also. So the practical empirical treatment for adult cap in suspected cap, you assess CRP, SpO2, ATS-IDS criteria, and on the basis of that you can decide with patient goes to OPD ward and also the ICU. Now this is the third case of an influenza which came to us. Multiple capillary lesions in the right upper lobe. You can see it up, as you see, they are there. So what we found, there was a markedly increased WBC, platelets were low, lactates were more than 2 but less than 4, and procalcitonin was very high. And in these cases, it was a post-influenza one, and there was, patient had a history of erythematous rash. It was and recurrence of tissue infection was there. This patient had come to us with pneumonia with respiration, plus the risk factor were leukopenia plus thrombocytopenia. If you find leukopenia, thrombocytopenia, and MRSA, please consider adding clindamycin. And then what we start in this patient is on vancomycin, and alternately you can start this patient also linezolid because it is a better lung penetration, and if you have a cavitation, it is not considered to be non-inferior to it, and you can add clindamycin if you don't want to use linezolid. Use linezolid once you have use clindamycin once you are using vancomycin, not other one. And MRSA nasal most of people don't do it, but they are recommended. Then the fourth case, this is a 50-year smoker, diabetes, 5 days stay in Bangkok. Again, it is important, the travel history. A lot of people are going to Thailand. For 4 days, he developed high-grade watery diarrhea, headache, and progressive dry cough. He was broad confusion. He had a marked, he was a hypothermia. Along with it, there was a relative bradycardia and marked apnea, hypoxemia, and bibasal fractures. We found the person had a hyponatremia, as in transaminitis, markedly elevated LDL, CRP hugely high, and CPK was also very high. Patchy bilateral low consolidation was there, and the classical glandular pneumonia, flu is a fever, diarrhea, hyponatremia, there were transaminitis, relative bradycardia, confusion, etc. And the patient has got focal pools, spikes. So this close exposure is very important. It's a close place. And diagnosis treatment, again, urinary antigen, you look, I will not go into it. Sputum culture, you should do it, but it takes long time. But what we are finding with the molecular diagnostic, we pick it up early, but the gold standard has been urinary antigen. First line of treatment is a macrolide and or levofloxacin. Or you can combine if person is too sick with the macrolide with the fluoroquinolone. And if you are not there, the rifampicin. But again, the bottom line is all these things, all are effective, but please rule out tuberculosis. I think in Indian context, that is important. 5 to 10 days of immunocompetency, more than 5 days after death, you need to give it, that means extended period of time up to 3 weeks. This is one of the, I think, the last case which I am discussing. A 21-year-old college postler presents with 2 weeks of low-grade fever, malaise, headache, and dry hand cough. 2 of his roommates have similar symptoms. Over the past 3 days, developed targetoid skin lesions over the trunk and extremities, and he had an oral and conjunctival mucositis and EFA. This patient we recently had around 6 months back with us. And when you examine, he was mildly febrile. He was also, there was normal oxygenation, and along with there was a history of bullous pharyngitis because of pain in the neck, pain in the eardrum he was asked for. And there were a few scattered bilateral freckles. Hemoglobin, he was anemic, and along with it, there was a marked evidence of suggest there is of hemolysis by seeing spherocyte as well as increased histiocytes. CXR showed bilateral reticular obesities, look worse than he does, and the CT showed 3-in-1 and bronchial wall thickening. This is a classical mycoplasma triad, also known as walking pneumonia. So here we have a cold agglutinin hemolytic anemia, extrapulmonary involvement, and obviously the atypical pneumonia, you have 3 groups of things, Mycoplasma, chlamydia, and Legionella. I think that is very important. For Legionella will be for the old smokers travel. That is where the history of travel to Bangkok or to Thailand was important. Mycoplasma will be young adults, and recently you saw that epidemic happening in China, and we had seen a number of these youngsters to us, 3 to 4 admissions we saw in the last 6 months. And the symptoms with the systemic features will be far higher in Mycoplasma vis-a-vis chlamydia or Legionella. And in these cases, again, the drug, this is what theoretical discussion. From the practical perspective, drug requirement is doxycycline, macrolides, or fluoroquinolone. And we use a lot of doxycycline in our institution, and fortunately, that is helping us out. But if it's a Legionella, then preferred drug will be quinolone provided you rule out. In these cases, streptococcus pneumoniae is the reference pathogen, will always stay there. This is the clinical lab feature. We saw the classical lobar segmental consolidation, rusticular sputum, pleuritic vein chest. Elderly men present atypically, but because of molecular diagnostic, we are making far common diagnosis strep pneumoniae. Earlier, we used to simply give beta-lactams, patient respond into strep pneumoniae. In these cases, we can also see a significant impaired spreading, very severe septicemic disease can be there. Again, high dose amoxicillin or amoxiclavinic acid takes care. Inpatient ceftriaxone is an excellent drug. If you are still down, you can use ceftriaxone with some time. Parasitic resistance usually is high, but unfortunately, nobody is checking it up. Macrolide resistance has increased in the US. Our data is roughly around 20%. So preferably use combination. If patient doesn't respond, is a step pneumonia. Look for complication, not resolving pneumonia, which Dr. Talwar. I've taken a long time. I'm just quickly finishing off. These are the 3 guidelines which are there. You can refer to them. But remember one thing, these guidelines are too weak to 12 years old. But here in Printer Dr. Allowance, we do not recommend. Please remove India major point is TB and TB. Take care of that. And second is a gram-negative organism, MDR. That is the second part which we need to take care. And third within the MDR is NDM. That's the third thing. If you take care of that, everything is there. Third is that procalcitonin will not be used for the diagnosis. It can only be used for de-escalation. Adjunctive therapies are the steroids. There's a lot of debate about it. But remember one thing, the borderline which I follow usually is the NICE guideline. And that's what we are recommending with a different thing. If you are finding that the consistently CRP is more than 150, person has an hypertension and a shock, and person has been on steroids in the past, and quite often we don't like that even in ICS people, baclomethazoline, present in the past, they can all lead to require the contact. So you need to select your patients well. Acute severe inflammation, don't go beyond 6 milligrams of dexamethasone. If it is in a hypertension, then hydrocortisone is the drug of choice to add total cortisone. And another thing which is happening in now is community acquired pneumonia is to act on the host response. Recently published paper where they are trying to use interleukin-1 and a pre-sepsis biomarker being used as it. I will not go beyond this. Then therapy and de-escalation is important. As far as the outpatient is there today, 5 days therapy is supposed to be good enough. It's an outdoor. But if it is an uncomplicated 5-7 days is good enough, you can follow them with the CRP. That's good enough. But if somebody has a bacteremia or Staph aureus, Pseudomonas, Legionella, lung abscess or complication, you need to use up to 3 weeks. Procalcitonin guided deconstitution is important, is helpful, but do not use every day procalcitonin. Take 2 to 3 times, 2 to 3 days different because of the properties of procalcitonin level. Markers of clinical stability are temperature, patient will become hypnotized, heart rate will slow down, respiratory rate will slow down. Why I am emphasizing on respiratory rate, people don't bother about it. They only look at saturation. Please look at it. If it stabilizes and person takes oral, you can switch. Again, switch over to beta-lactam. There is a tendency in our clinicians to shift over to paracetamol. Nobody recommends that. It is a costly drug. Unnecessarily we are using it up. Please use amoxiclavinic acid, cefixime, or a clavinic acid, or you can use macrolides, etc. I'm just jumping it up. Complications can be local, systemic, long-term, and more important, the paraneumonic infusions and empyema, abscesses, and PPF which can happen, especially the medicines which can come up. Systemic, we all know septic shock and ARDS, which are the consequences of hypotension and shock. And again, heart failure related fibrillation is not uncommon. Hyponatremia, you will see straight away take you to Legionella. Long term, there is an increase. We are finding mortality, and cardiovascular mortality is very high, and that's what we saw after COVID also. It's not only viruses, it is after the bacteria. So please be very careful, check your patient regularly, and when you're using as a throat erythromycin, please look at QTC. Prevention is important. Today we need to talk about influenza, we need to talk about pneumococcus, and also pertussis. Smoking cessation, we don't try it, but we need to convince some patients about it. This is the last slide, my dear friends. So this is from the Lancet. When the patient comes within 4 to 8 hours, you need to do the severity assessment, site of care, do microbiological testing in severe cap, not otherwise, and clinical antibiotics and supportive care. After 3 hours, 3 days, or 72 hours, look for clinical stability, check microbiological result, do a reassessment of antibiotic, switch to oral and duration. Clinical reassessment is the key. Repeat when, how. I think there's no need unless a patient is responding, you don't need anything. Change antibiotic only if a person is having non-response, or you find a culture report has come which is negative or molecular diagnostics, you are realizing there are multiple resistant genes and we have probably chosen the wrong antibiotic. And discharge assessment is as important for us. Follow schedule is important. Vaccination we must do. Rehabilitation is the key. Reintroduce all previous medications as well as chest radiography is routinely not required, but at best you can do it at 8 weeks. That is the long period which is needed and required. And very fundamentally is look after the heart of this patient and take colleague from you. Thank you very much for patient hearing, and Dr. Chawla, apologies for going and exceeding. that
no
time.
problem since yesterday. कल सुबह तक भी थोड़ा लग रहा था, अभी भी है, but now it's fine. So this is my son. You check that.
Thank you, sir. Thanks for that
Yeah.
elaborated talk. And I mean, it's
So
quite a
we
bit
both
of a
are going for
topic,
trek.
so it was
Next week, no?
very
This
well
week we are
covered.
going
Chawla,
Thursday.
sir.
So I need medical certificate signed.
I think he's a master,
It says
but he
we
had
don't
too
have
much
heart
material to
disease,
talk
we don't
about.
have this, we don't have that.
He could have spoken for
We
1.5
see
hours.
that if any
Very nice
specialty they will ask means you have to do the test.
Thank you, sir, but apologies. I think I got a little successful. So
Not
I'm sorry, Dr. Talwar.
examination.
Apologies to write in the back.
So many things it is there.
No, you check.
Thank you very much, Dhruv, that you covered some of my topics. So I will be relieved to skip few slides.
So we'll move ahead with the next. Just an announcement for the participants. After this talk, we are going to have a panel discussion. So request,
You have to do
please
some blood
post your
tests.
question in the chat box. We'll
Blood
take up
test
as we
and
come with the
ECG.
next talk. So next talk is
Sugar,
what we have is
asthma,
by Dr.
epilepsy,
Talwar.
heart epilepsy,
And
nothing it is required.
just to name his
For
acknowledge,
heart
Dr. Talwar is
condition,
Director and Chair,
asthma, chest
Pulmonary
X-ray
and
it
Sleep
is
Critical
required.
Care Medicine
Random
and
blood sugar it is
at
required.
Metro Center
And
for Respiratory Disease,
kidney
Noida.
test also
He
it
is
is
also
required.
is teaching in charge
They are
DSP and
asking
Respiratory
liver or
Medicine
kidney
since
disease.
2028
Doctor, it is
and
not
fellowship
ICU.
program
Sir,
in
I won't
pulmonology
sign it.
under IB and ICS. To his name, he's got more than 246 research papers in index
Because
PubMed
anything goes wrong, I'm
journals,
not
high
only
index
the
journals like
responsible
NEGM
person.
and Clinical Infectious Diseases, BMJ, Chest and
And they
Respiratory,
are asking
Asthma,
specifically
Allergy
the
and Clinical
particular things
Immunology, and also in
which we
American
can't
Journal of
neglect.
Respiratory and Critical Care Medicine. His citations are more than 4,400, H index 22 and I-10 index 47. And today Dr. Talwar is going to speak on the when antibiotics fail, approach to non-resolving pneumonia in CAP.
Who said
Stage
that?
is yours, Dr.
Generally,
Talwar.
they
We
say
are
take
really
half of
thankful
the
to you
morning, half of the
for
night.
joining us.
You ask them what is the
Bharat,
use
he
of
is the
Dialox.
Amitabh Bachchan of the pulmonary.
This is for eye
Yes,
disease.
so we all know him.
Ah.
Even the critical
You
care
do the
medicine
Google
start
ECG
with
that.
he had quite a bit of accolades and paper in his name. We are
This
aware.
is
And I'm honored to meet him at many other meetings. Sir, you can carry on with the talk.
And the topic given to me by
No, why
Rajesh
you
is
want to take
approach to
you have any
non-response
issues?
pneumonia when
No,
antibiotics fail. I think that's a very good thing.
What is the relation
And
between
this is something which is
attitude
common
sickness
because
and the ties?
7.5% of
So it happened
outpatients
to my son
who
last
are
year.
treated as a pneumonia
Diamox. He
fail
failed all night and he came back.
and require
I
hospitalization.
don't know, sir.
1 out of 4
But we are not
accounts
providing.
for hospitalized
No, I'm not
pneumonias
asking
where
you
again
why,
they
I'm just
fail.
asking you,
And
is there a
15%
correlation between
of
Nothing it is
inpatient
there.
pulmonary consultations
No
come
correlation.
primarily because the patient's pneumonia
We won't
is
suggest
not
also.
going away.
Don't
Means
take Diamox,
antibiotics are
no
not working.
connection.
So, what is this so-called as resolving pneumonia, which is not resolving? So, non-resolving word which has come up. What does it mean? So, for that we need to understand what is the normal resolution. So, if you look at it, the first resolution which comes always is a microbiological, where the bacteria are eliminated first. And once the microbiological load decreases, the second resolution comes in the clinical and the inflammatory markers. Radiological clearance is always the last to happen, and it takes normally 4 to 10 weeks. And it can be much longer in people who are elderly, who have severe community-acquired pneumonia or underlying severe chronic obstructive pulmonary disease. But remember, microbiological clearance is not equal to clinical cure, and clinical cure is not equal to radiological clearance. What it means is, everything goes well, still radiological clearance may occur after many, many weeks of the patient being completely alright. So we are talking about a normal response to what is not a normal response. So non-response. So non-response is either of the two things. There is absence of clinical improvement, which is generally kept at the window of 72 hours, which Dr. Dhruva has already said, that 3 days. So at 3 days, if the patient shows no clinical improvement and the patient is on appropriate empirical therapy, we therapy which has been given to this patient. So I think this window, which is given 3 days or 7 earlier slide itself, that elderly people will take longer to respond. You need to give that concession. If people have suppressed immunity or a structural lung disease like COPD, then also they will take much longer time. But a very important aspect is a factor 2, which is related to patient or the bug. So in this situation, what is important is the bugs. So if you have unusual organisms, then obviously there will be a delayed response, because some of them are known to have a delayed response. And Dhruva has very nicely dealt with all these organisms, including atypical bacteria or atypical infections. More importantly will be an abnormal pathogen which has got a multi-drug resistance, which is like Klebsiella, very elaborately discussed by Dr. Dhruva. Moving on to the third factor are the drug issues, where we have taken actually a choice of antibiotic which is inappropriate, or either we are underdosing, or there is a poor tissue penetration, like if the patient has developed empyema and the drug is not able to reach. Moving on to the fourth important factor of a non-resolving pneumonia is developing complications. This all has been already highlighted by Dr. Dhruva, that sequestrated infection foci like abscesses or empyema, they block the drug access and hence the resolution or the response gets delayed. But last and not the least, and a very important, which accounts for nearly 30% of these patients who are labeled as non-resolving pneumonias actually never have a pneumonia. And these are called non-infectious mimics. There can be malignancies, immunological conditions. They can all look like and behave like infection, but they are not infection. I'll quickly move on to a couple of slides faster. That what is a normal kind of a response which you see in a patient, and if you see this slide, it will show you that the radiographic clearance is very much delayed, and if it occurs rapidly, it's perhaps mostly in the patients which are atypical bacteria like Mycobacterium pneumoniae or Chlamydia pneumoniae. But the classical ones like Streptococcus pneumoniae can actually take up to 1 to 3 months, so it takes some time. So remember, there is a lot of lag for a radiographic clearance. Don't believe on that. Go for a clinical markings as well as look for the deterioration, which is more important to pick up non-responsive pneumonia. So worsening of the clinical parameters or radiographic deterioration are generally the features which are very important to be considered. Radiographic deterioration is very important for Legionella, and clinical worsening is very important for Streptococcus pneumoniae. And we need to keep all these things in our mind. When we look at the host factors, which are the hosts which are likely to take longer time to show the response in a classical community-acquired pneumonia. So these are the people who are elderly, as I said, but very importantly also, they are at high risk for gram-negative bacteria and pseudomonas, people who have a high risk for MRSA, and people who have a risk for aspiration, malnutrition, and impaired neutrophil function, like alcoholism. They will be all responsible for showing a delayed response. Patients who have COPD, poor lung functions, advanced age, catheters, burns, they are all candidates for a slow response to happen and more likely to go into a non-resolving. The question which has been very nicely dealt by Dr. Dhruva, and in fact Aakanksha has also dealt with, that whenever the patient is not responding, it doesn't mean that you need to escalate the therapy. But when you are at the helm of affairs and the patient is not responding, then the first thing you tend to do is actually escalate the antibiotics, because there is a risk of under-treatment. You might be missing an MDR gram-negative pathogen because a lot of the times the cultures are not very good in quality, quantity, as well as the reporting. And also, if there is an under-treatment, there is always an element of fear that this may further progress to ARDS and septic shock and go on to perhaps an irreversible journey. But always need to remember that there are risks for over-escalation. Antibiotic toxicity, organ injury can all be caused by excessive use of unnecessary antibiotics. And it can also amplify more resistant bacteria and more resistance producing bacteria in the lungs and make the treatment much more difficult. And never to forget that Clostridium colitis is a major mimic of sepsis, and it just looks like that. So I think the core principle to remember is, if there is no clinical decline and there is no clear microbiological proof, it's not reasonable to escalate. I think it has been highlighted very well right in the beginning by Aakanksha and emphasized and overemphasized by Dhruva too. So just absence of clinical decline or a clear microbiological proof is highly reasonable that you can say, let's not escalate, just have a patient, watchful waiting and let the things unfold over a period of couple of hours to a day. I think Dhruv has made a very good point repeatedly about the tuberculosis burden and confusion in community-acquired pneumonia. That is the one point which has been raised very seriously, that even 5 days of use of ciprofloxacin or levofloxacin to treat the patient of community-acquired pneumonia actually can give a setback of actually picking up acid-fast bacilli by 19 days. So your diagnosis of tuberculosis gets delayed by almost 19 days if the patient has received for that particular infection of fluoroquinolone. So that's the precise reason that fluoroquinolones are the last choice to be given, contrast to all guidelines which are in the West, which is giving upfront choice of using fluoroquinolones. So there is a clinical illusion where it happens that you give community-acquired pneumonia patient fluoroquinolone, they do better for some time, but then they explode, which is like typical pattern that it was a tuberculosis which has finally got exposed in the patient who was having perhaps a dual infection. So I'll bring this patient, which is 37 years male, a never smoker, had a fever, cough and sputum of 5 days with no significant comorbidities and a left basal crackles. This chest X-ray may not look so overwhelmingly bad, but and also his labs, which shows the TLC of 9,600, CRP was very high, 333, PCT 0.5, LDH 273. Sputum had no growth for us, and we continued to treat him on the guidelines. He was given an IV amoxicillin clavulanic acid and an azithromycin, and he continued to worsen, and on day 4, actually he developed a respiratory failure, a lot of hue and cry. So we should always remember that whenever there are atypical decompensations, there may be co-infections which are very beautifully highlighted by Dr. Dhruv, that influenza, RSV, and human metapneumovirus and para-influenza viruses are all there along with bacteria, and there may be not one organism which is driving the instability in the patient, but the other one which is perhaps not detected, not treated, or perhaps there's no treatment for that, may be responsible for development of acute respiratory decompensation, and which is like very difficult to pick it up because these organisms are now only can be picked up by the PCR-based methods which are done on a BAL. Otherwise, also there could be opportunistic infections, and many times we have also seen invasive aspergillosis in these patients. So coming back to this patient, which X-ray didn't look so bad, you can look at the CT scan. So it was all hidden behind the chest X-ray. So that clearly brings into the point that CT scan is required many times when things are not going right. And this patient's urine for Legionella antigen came out to be positive. Patient was put on to levofloxacin, which we never use upfront, but now because of Legionella, we started him on levofloxacin, and 7th day he went home normally. The next is 63 years female housewife, and she has a fever, cough and sputum of 5 days. Again, no comorbidities, and has left basal crackles. Most of the findings are okay, except the CRP PCT, sputum non-diagnostic. CT scan was done again because there was very subtle findings on a chest X-ray. And you can see that there are some mediastinal lymph nodes as well as a pattern of bronchiolitis with a lot of nodular opacities suggesting of airway-centric inflammation or infection in this group of patients. So again, this patient was finally tested for chlamydia PCR and BAL positive and given clarithromycin for 2 weeks. So such kind of infections do occur, and they are sometimes very difficult to diagnose. And like in this one, it never responded to azithromycin where it should have. But the switch to clarithromycin actually saved the patient. Moving on to the next one, you will see this patient who's a 74 years male, never smoker, a teacher, and a resident of Singapore. I think a very important point was raised by Dr. Dhruv that where is the patient coming from, where is he resident of, is equally important to look at the endemicity of the kind of organisms from that area to cause pneumonia. He had a significant weight loss of 3.5 kg, and he had other significant cardiac comorbidities as well as diabetes. His hemoglobin, his HbA1c was showing uncontrolled diabetes. CRP was high, PCT was negative, LDH was slightly high. Again, sputum bronchoscopy was done, and everything was non-diagnostic in this patient. And you look at this, a transbronchial lung biopsy. And if you pick it up, that clearly you can see a lot of fungal elements into this, and this is a histoplasmosis. So his travel from Singapore goes back to the history, where he was going and playing with the animals in the Singapore parks. So this is another one. He's a 73 years male, a farmer. He also came with fever, cough, and sputum with worsening of shortness of breath for 10 days. He has hypertension as well as COPD. He had some basal crackles, chest X-ray again, not very remarkable, but because of COPD, we can see huge sized lungs. Labs were mostly normal. The sputum grew Klebsiella. We gave antibiotics as per sensitivity, but still no response. He underwent a radial EBUS. And you can see that again, and you can see the fungal elements out into the lung tissue, extensively invading, and this was a cryptococcosis. So, moving on to the next one. This is a building contractor. Again, a very important thing to look at the occupation of these patients. And ex-smoker, 61 years male, fever, cough and sputum with occasionally stained with blood even for 1 month. Took multiple courses of antibiotics, no effect. Diabetes and hypothyroid was there. And this patient had a slightly raised TLC, 12,600, HbA1c of 8.9, and the sputum was negative for everything. And this was the kind of, again, X-ray and a CT scan, which you can see here. So completely hidden from sight is again a lesion, which was behind the diaphragm, and it is on the right side. So you can see quite a big lesion out there. And it was because he has undergone so many tests before, he was not ready for anything further. A PET scan did show this, and we finally decided to do a CT guided biopsy for him. And you can see in the CT guided biopsy, again we are trying to show you the fungus, which is Aspergillus hyphae all over into the lung tissue. But the second part, which is again related to infection and not the kind of organism, is when the infection goes and hides somewhere else where the infections cannot be treated because the antibiotics won't be able to reach there, which is a blind spot. So these kind of blind spots can occur where there is a loculated parapneumonic effusion. Through again, I've spoken about it. And these are the sometimes even abscesses which are formed in this consolidation where antibiotics are not able to get direct access, and hence the antibiotics are not effective in controlling the infection. So at this point of care, a lung ultrasound is very sensitive to pick up complex septated pleural effusions, and drainage of them is all that is required rather than just changing the antibiotics in this group of patients. One question which I think Dhruva has very rightly pointed out is, can biomarkers help in pneumonia? So in the diagnosis of pneumonia, as he very rightly said, there is no role. But when you follow up these patients and you want to see non-resolving pneumonias, then there are these kind of three patterns which you can see with CRP and PCT and clinical improvement. So if CRP drops to less than 30 or there is more than 50% reduction on day 4, then it shows excellent prognosis. Mortality is only 0.5%. But if the PCT is rising and there is a clinical deterioration, this is high risk of treatment failure. So you can see a biomarker with a clinical deterioration. And this is treatment failure or an MDR organism or a new complication happening, it will require a diagnostic evaluations. But if the CRP is flat or slightly rising with the PCT, but patient is still doing well, so it may be just delayed clearance and does not dictate escalation of antibiotics. So here we can just sit and watch and wait how the things turn in the next couple of hours or perhaps days. So a clear warning is, do not use PCT guided escalations of antibiotics, which Dhruva has also very rightly pointed out that it has been shown to cause more organ harm as well as prolonged ICU stay and not better survival. Finally, there are non-infectious mimics. Clinico-radiological features look like pneumonia. We presume it is infection. We start empirical antibiotics. Patient shows failure to resolve or worsening of hypoxia. Now we need to investigate for non-resolved pneumonia mimics. Mimics are those which requires active elimination by some kind of more invasive test in this group of patients. And that brings me to this patient who's 81 years male, non-diabetic, non-hypertensive, PTCA on Amitron for 2 years and with a pacemaker in C2. He has cough, fever, shortness of breath. He is treated with multiple antibiotics for left lower lobe pneumonia, which was failure to resolution, and the biopsy was done, and you can see that classical foamy alveolar macrophages in the transbronchial lung biopsy from the left lower lobe showing Amitron-induced lung toxicity. So many a times what looks like pneumonia is actually not a pneumonia, and it's not the antibiotics which have failed, it is actually we have failed to pick up the right diagnosis. Moving on to the second case, 35 years old male and a non-smoker. It's a clinical trap because patient has cough, fever and shortness of breath of 3 weeks. All looks like that this patient has some kind of an infection in the lungs. He has been obviously receiving multiple antibiotics with no clinical relief. There was a doubtful shadow on the left side and not very clear on a chest x-ray at all, but CDPA clearly showed bilateral pulmonary embolism. So pulmonary embolism can lead to infarction or hemorrhage, which looks like pneumonia. And when there is, the important thing is DVT may not be there at all. So don't look for DVT to pick at peak. Just keep a high index of suspicion to rule out pulmonary embolism in kind of such patients who are actually looking very obscure from any aspect, whether it is a community-acquired pneumonia or any other mimic of community-acquired pneumonia. The next is a 76-year-old male who's an ex-serviceman and a former smoker who comes primarily with the fever, cough and brownish sputum for 2 months. Multiple antibiotics, negative FOB and significant weight loss. You can look at the chest x-ray, the right-sided pneumonia, the CT also showed, and of course the sputum itself showed that it is adenocarcinoma, and you can easily pick it up in a back pattern. Even such samples can be also confirmed for EGFR, like in this patient who had exon 19 deletion mutation. So everything which looks like pneumonia can be even cancer. So, and sometimes these kind of things can happen in real life where you need to do a more invasive tests. The next is a 34-year-old female, and she has fever, cough and shortness of breath for 1 month. Antibiotics failed, even ATT was tried to her because she had a cavity lesion on the left upper lobe. You can see on the CT scan. And the standard diagnostics like FOB and lymph node FNAC were all inconclusive. And the unmasking required actually a true cut lung biopsy which revealed a Hodgkin's lymphoma. So malignancies can very clearly mimic like pneumonias which are not resolving or which are refusing to go away. This is the next case, which is 23 years female, fever for 1 month and dyspnea for 15 days and a weight loss of 8 kgs in 6 months, last 6 months. So that means something was going on for a couple of months, although the history was short of about 1 month only. She was pale and she had a very low saturations on room air and she had crackles, and she primarily arrived with raised TLC, PCT positive, CRP high, and everything was deranged, urea, creatinine, so made as a diagnosis of bilateral pneumonia with sepsis and everything. And you can see that the CT scan also shows the bilateral infiltrates, and this is a very great mimicker of what looks like a severe pneumonia, but actually it is not. And this is a diffuse alveolar hemorrhage where sequential BAL actually leads to develop clarity in this situation. This is not a BAL from this patient because he had many other tests which came out to be positive for this. So we will move on to one more case where it is a 54 years female, non-smoker housewife, fever with chills, cough and sputum 10 days, antibiotics no effect, no comorbidities, and examinations, again the left-sided coarse crackles were there. TLC high, CRP high, PCT negative, sputum non-contributory, bronchoscopy non-contributory, and you can see the CT scan, there is a big opacity on the left lower lobe. And a biopsy showed what? Classical chronic, cryptogenic organizing pneumonia. COP. So they look like pneumonia, but they are not pneumonia. And if you do not find any cause for them, then only you label them as a cryptogenic organizing pneumonia, which actually puts them into a new ILD definition of AMP. And perhaps this is one of the last one or two cases, which you look at 70 years female, non-smoker, low-grade fever, dry cough for 15 days, diabetic, arthritic patient, 92% room air, and multiple crackles everywhere. So bronchoscopy, TBLB done for this patient, and you can see this again, it is showing an extensive inflammation, which is related to some kind of aspiration, because there are particles which are the food particles staining into around the granulomas, which is showing that this is a aspiration of the food particles leading to bilateral lower lobe aspiration pneumonia in this patient. This another patient is very interesting, 74 years ex-smoker, again fever, cough and sputum for 5 days, and diabetic, COPD on LGOT, saturation 82%, crackles on the left side. You can see this, there's a quite a big opacity, admitted with a pneumonia, TLC count high, CRP high, PCD negative, sputum, FOB, nothing suggestive of anything. Finally, required a radial EBUS, and it showed a classical adenocarcinoma, large cell NET tumor. So all kind of tumors and autoimmunes, pulmonary embolisms can mimic something like a pneumonia. And this is last, I think perhaps where we saw that 52 years female had taken everything possible for the last 4 or 5 days, was running hectic fever. And the TLC count was 13,000, eosinophils were 430. She had Klebsiella, we were happy, we started treating her, she never responded, and we did a CT guided biopsy. And what we found was absolutely chronic eosinophilic pneumonia with multiple eosinophils throughout it, and there's a lot of organization along with it, showing that this is not that acute. It has gone on for a couple of days by the time we have been able to make a diagnosis of chronic eosinophilic pneumonia. So the things become very difficult, because when we talk about diffuse alveolar hemorrhage, only 30% patients have hemoptysis. When we talk about a chronic eosinophilic pneumonia, nearly 70% of the patients only have eosinophils in the blood, and there is no driver to tell us that there are eosinophils going to be in the lungs also. Similarly, there are pictures of malignancies where they exactly mimic and present like pneumonias, and a much deeper investigations are required. So how do you work up a non-resolving pneumonia which refuses to go away? So from simple to the maximum, or the most sophisticated test, or from something which is easy to perform to something which is the most difficult, something which has got less side effects to something which has got more side effects, is lavage, bronchoscopy, CT guided biopsy, and a wax biopsy. So in my own opinion, or my own memories, now very frequently wax biopsies are done, because most of the time bronchoscopy with a radial EBUS biopsies is able to achieve the diagnosis. And if the lesion is peripheral, then CT guided lung biopsies are of great help. So I'll summarize and end here that whenever we see a non-resolving pneumonia, we need to reevaluate the host. Look at the comorbidities, look at his age, and look at the risk factors for delayed resolution. If not, we move on to the bug, reevaluate the bug, check the travel history, occupational exposure, culture results, and keep looking at that again and again if you get a culture negative test, and perhaps go on to the PCR based techniques in patients where we are really stuck. Once we move on, the next step will be advanced imaging, and here of course thoracic CT scan makes a lot of difference, but not to miss pulmonary embolism, because that sometimes mimics exactly like a pneumonia, which is just not going away with antibiotics. And finally, to take the respiratory tract sample through bronchoscopy or a targeted lavage, and this is particularly useful for doing PCR based tests to pick up atypical organisms, unusual organisms, and of course viruses. And finally, when nothing else works, we do a lung biopsy, which is an invasive procedure, can be, as I said, done by CT guided or by the radial EBUS guided, depending upon where the lesion is spread. With that, I would like to thank you all for listening. I think even I have overshot my time. I think even I have overshot my time. I'm so
No,
sorry.
that's okay. Okay, sir. I mean, it cuts my time then because you both of you covered very elaborately. So I don't have too many questions to ask both of you. So we'll try to cover up the things and we'll just ask to the panel. So it was nicely elaborated, sir, and good discussion to have now. Can I have all the panels on board? Dr. Aakanksha, Dr. Dhruva Chaudhry, and Talwar, sir.
I'm there.
Yes.
Just stop sharing.
I'm
Yeah.
still sharing.
Good talk.
Am I still?
Yes.
Yes, sir. Yes, yes.
Okay, because that is why I was. Oh, it's showing share at the moment. Is it still there?
Yeah.
We are seeing a very beautiful landscape.
So,
Here you can see,
is this Dr. Chawla's screen? I will
Yes.
just check whose screen.
Again, press the share and then stop sharing.
Cease, remove from toolbar, share setting. Actually, at my place, it is showing share rather than stop sharing.
So, it's someone else's screen.
and this is
Which is the screen coming?
The blue
It's
color,
a-
Blue, only blue color, nothing else.
Now it has
now it's done.
Stop, sir.
It's done. So, I'll start with it, sir. The first question is, sir, it's about the ATS